Okay, well, welcome. So we're going to get started. Glad everyone could make it. And this is a different version of our normal Tuesdays to Your Health. So I'm doing it in the pleasant atmosphere of my work on my home office. So I'll give you a nice little tour you can see here. And I look forward to doing this again, hopefully in the next several months to come back at Cavallo Point once we reopen and things start moving along and we start reintegrating back into a society as a different version perhaps as we know it, or knew it, but nonetheless back at Cavallo. We will continue to do this live stream, probably through Zoom like this. So feel free to spread the word. It allows people to, people have been asking me for several years to bring it online so people that are outside the Bay Area can join. So I'm glad we're able to do that. So tonight we're going to talk about digestive health. And we've got about 30 or so slides to go through. We're going to cover a range. I'm going to give you some basics about the general anatomy of our gut. And then once we understand that, how we break down food a little bit, so just to understand the nuts and bolts, where nutrients are absorbed. And then we're going to move and talk about different health issues related to digestive health. So some of these may relate to you, some of them may not. We're going to talk about, irritable bowel syndrome. We're going to talk about gas and constipation and intestinal permeability. Some people call it leaky gut. Also small intestine bacterial overgrowth. So we'll cover a few topics and then we'll leave some time on the backside to do some questions as well. So let me go ahead and get these slides up so you can see them. Give me a sec here. All right. So let's see if that. Great. So I guess I'll give you a little bit of backdrop just to fill you in on what's been going on for those that haven't been attending. I'll just back up and tell you that on my YouTube channel, which I've given a little bit more attention to now, we're doing weekly webinars focused on COVID-19, and each webinar focused on a different topic. And then when we do those webinars, it's for my practice, for my patients, and then I'll go ahead and post them afterwards up onto YouTube, on my YouTube channel. So if you're interested in watching those, feel free. It's Dr. Brad Jacobs. It's pretty straightforward on YouTube, Dr. Brad Jacobs. So feel free to check that out. So that's going on about weekly. And the other initiatives, just so you know, if those that are interested, there's a huge crisis around personal protective equipment, as many of you may have been hearing, for healthcare workers. And so we've taken some action around that and now have formed a 501c3 focused on just that. And it's called Humankind Now. And it's focused on, it's an online exchange where we're identifying N95, primarily focusing on surgical masks and N95 respirators or masks for healthcare workers. So we identify it from the manufacturer, getting it through the supply chain, bringing it here to the United States, and then distributing it to healthcare providers, organizations, hospital systems that are in need. We did our first shipment to the San Francisco Veterans Hospital, and we doubled their shipment that they got from the federal government. And that was a small shipment. That was 5,000 N95s, and they had only received 2,400 N95s from the federal government over the previous 6 weeks. So anyway, we're sort of revving that up. If you're interested in donating or interested in volunteering, feel free to go to humankindnow.org. Digestive health. So there's a lot to cover. Let's just lay out a bit of the anatomy first, give you a little bit of lay of the land. So as you can see here, we do a bit of chewing that starts at the top of our digestive tract, namely our mouth, and then it goes all the way down through the esophagus, into the stomach. Then that goes into the small intestine, then the large intestine, and out through the rectum. As a side note for COVID-19, they're seeing a large amount of COVID-19 actually in fecal matter. So it's in the stools. As a matter of fact, in Los Angeles, they're thinking of doing a study looking at the wastewater to get a sense for seroprevalence of how COVID-19 in Los Angeles by looking at wastewater. And previously with the coronavirus, they also found this actually in sewage systems. So in China, actually, they documented an outbreak where someone with SARS, someone went from one region of China where there was a SARS outbreak, visited another region in China, went into this apartment complex that was made up of 8 large towers. He went into one of the towers. They all had a similar elevator, single elevator going up through the towers. He went into one of these towers, visited his friend a couple times, obviously used the toilet because they had an outbreak in that one building, not any of the other buildings, just that one building. And it was sporadically, not just in that unit that he visited, but in other units. And they traced it to the sewage line. They found out that as the sewage from the toilet was going down the line through the building, down and out, they followed that particular sewer line because there were multiple ones exiting the building. And that's where all the cases were. So somehow it was aerosolizing through the sewage line. A side note, but relevant, is to note that some people present just with diarrhea. It's rare, but you'll see more studies coming out showing more and more of this, but people can have nausea, loose stools, diarrhea related to COVID-19. That's not the topic tonight, but since it's topical for all of us, I thought I'd mention that. And it's not published in any studies formally yet, but it's definitely known amongst gastroenterologists and others that are deep into the space. So if you sort of think through now and you want to talk about what, as you go from this and think about the structure and now how does it actually function? And how do we create an optimal environment for healing versus a less optimal environment for healing? And you can see on the right the negative balance and on the left the positive balance. So if you're looking at just our nervous system and sort of our sympathetic drive and how that plays into our digestion, we all know that if you're nervous, you can get upset stomach, you can get loose stools, some people get constipated, etc. And that relates to our stress and our sympathetic drive and our parasympathetic tone, which is sort of the braking side, the calming side of our nervous system. And then as you move down, look at the stomach. We have a certain amount of acidity in that stomach. It's supposed to be at a certain level, roughly a pH of 1 to 3. Sometimes it can be too acidic or not acidic enough. Sometimes as we get older, we don't produce enough hydrogen ions. We don't produce enough and we can get a problem where we don't have enough acid in our stomach. Or some people produce too much acid when we're highly stressed, hence the drugs proton pump inhibitors, which we'll talk about later. And then as you move down, what's the bacteria like in our gut, in our small intestines, and in our large intestines? Do we have large intestine bacteria living in our small intestine? That's called SIBO, or small intestinal bacterial overgrowth. Do we have the right intestinal bacteria in the right locations, in the right types? So if we sort of just bear that in mind as we're going through here, and the other thing to keep in mind is that barrier. There's a gut immune barrier or a gut blood barrier that lies between that where the food comes down through the gut, through the intestines. Then there's this brush border, which we'll talk about, and then it needs to make its way. The nutrients need to make their way in the partially digested food products as carbohydrates break down, as proteins break down. They make their way across into the bloodstream. And that border has to be tight. If it's not tight and it's letting things across that shouldn't be coming across, we can get an autoimmune reaction, an over-inflammatory reaction, and causing problems. So think of gluten intolerance or celiac disease, for example. All right. So the other parts that really help the system function and digest food and help us stay healthy are the liver, which metabolizes lots of toxins, whether it's medications, whether it's food groups that we're eating, or whether it's hormones and medications, right? So all sorts of things go through the liver. That's the primary metabolism of our body. The kidney plays a role as well, of course. The lungs, we can expire and we actually release things through the lung and the skin. But the liver is a big one. Gallbladder, again, for digesting fats. Pancreas also for digestion of large, you have sugar in there with insulin. You have fats. There's a range of things that are going on with all these different organs. And then we can think about each different large, what I call sort of what we all call macronutrients. So we have got carbohydrates, proteins, and fats. So when you think about carbs, they're broken down into smaller components called sugars. And that happens where? It starts actually in the mouth. So your saliva helps break down products in the mouth. And then as you goes down into the small intestine, working their way into the stomach, and working their way into the small intestine, the pancreatic amylase and then liver enzymes in the duodenum start to break down those carbs. Proteins similarly get broken down to amino acids by what? By the acid in the stomach. And we'll talk about this a little bit later, because when you take medications to reduce the acid in the stomach, then your proteins don't necessarily get absorbed correctly, and that can cause problems. Fats are broken down into these tiny little components called micelles and fatty acids, and that happens by the lipase in the pancreas and the biliary tree. So what happens in the large intestine? So now if we move through the small intestine to the large intestine, that's where most of the water gets absorbed. So when we're having diarrhea, like, if you eat poor food, something's wrong with it, you get diarrhea. A lot of times you're having it related to the large intestine. It will stop absorbing because it doesn't want to absorb all that content because it knows there's some toxins in it, and it just stops, shuts down, and then all the fluid comes out as diarrhea. So a big piece relates to bacteria. How plentiful is your bacteria? And that's where the bacteria down there will digest the remaining carbohydrates. It also, you can get gas produced down there. That's where we manufacture our vitamins B and K. And so that's sort of the lay of the land, if you will. When you think about nutrient absorption, it's like we talked about earlier, the small intestine, the integrity of that lining is really important. And the cause of a lot of problems are either bacteria in the wrong part of the gut. So this large intestine bacteria is in the small intestine zone, which is the small intestine bacterial overgrowth. Or we have these permeability issues we talked about. Or you might have some bacteria in there that can be harmful. It's not healthy. And that's the microflora we're talking about. It could be parasites. They could be a range of different sort of organisms, if you will, that may not be pure pathogens that cause disease, but they can cause some dysregulation in our ability to absorb nutrients correctly. And there's testing we can do for that. And then we have sort of our pancreas and biliary tree of the gallbladder, and how well is that releasing and functioning too. And then, of course, infections. So if you break it down, you think about vitamins and electrolytes and water. These are sort of what to think about. Well, if there's fat-soluble vitamins, we have water-soluble vitamins. We have B12, which really needs, in order to be absorbed well, has to bind with something called intrinsic factor. And when that doesn't work well, then people, even if they take oral vitamin B12 by mouth, if they don't have the intrinsic factor working right, the B12 levels won't increase. And so you either need to fix that underlying problem, or you need to actually give someone B12 injections, or I would say. So let's move into sort of the health part of the conversation. And just give me a moment. I'm going to pause. Just looking at a couple questions that were placed. If you do have questions, feel free to post them. So, food allergies and intolerances. Those are the big sort of categories. There's true food allergies, which can really be a problem, right? Think of peanut allergies in kids in particular. Shellfish allergies. You can have anaphylactic reactions. People have hives and welts and trouble breathing, and the lips can swell up. They can get angioedema, it's called. They can get throat swelling. So that's those are serious issues. I'm going to talk to you a bit more about intolerances. And so if we think about that, what does that mean? So frequently after a GI infection, people can develop intolerances. So for example, my son, this happened to him about 6 years ago. So he had a bad GI bug. We went fly fishing up in Montana, caught a GI bug, had a fever, it was pretty bad. Next thing you knew, when he ate gluten, he started getting stomach aches. It took us a while to figure out that it was the gluten. We thought it was residual from this incident, and then he was just having issues. And then we realized actually it was related to mostly gluten. This happens to a lot of people. It's a well-known phenomenon, whether it's E. coli infection or Campylobacter infection. Lots of different organisms can then all of a sudden shift. And we don't know why. There's some theories. One theory is if you're eating, for example, a lot of gluten while you're infected with this organism, your immune system may misread gluten, because you're eating a lot of bread, let's say, for this organism. And so it's sort of, from that point moving forward, still has a reactive response to gluten because it's misidentifying it. It's never fully been mapped out, but it's definitely a real phenomenon. What happens to people? They can have GI symptoms or non-GI symptoms. So that's the part that's a little confusing for some, particularly for conventional doctors who mostly say, if you're not having GI symptoms, you don't have a food intolerance. But I can't tell you time and time again, I've had people have headaches, migraines, for example, or they have rashes, or they have a range of different things that aren't GI based. And sure enough, you remove something and all of a sudden they feel better. You know, in the past decade, I think more and more people in the public, most of you probably listening, know this. Unfortunately, only a minority of physicians actually aspire to this. As many of you know, I've had a pretty major interest in integrative medicine, the field of integrative medicine, which includes functional medicine, which many people hear about these days. And we spent a lot of time really focusing and trying to broaden both the conventional physician's mind and sort of broaden their view to help them expand to things that they hadn't originally learned in medical school that have subsequently changed, as well as to try and help patients find really, you know, helpful and open-minded, evidence-informed integrative docs. There's a group called the Academy for Integrative Health and Medicine that I'm on the board of. It's a nonprofit focused on educating clinicians of all walks, so acupuncturists, pharmacists, medical doctors, nurses, the full gambit, chiropractors, naturopaths, so that we can learn and work together. So we actually train people together. There's fellowships we have where they cross-fertilize and they train side by side. And we also are doing sort of, you know, a range of both direct to consumer, so straight to the public, but also town halls and chapters. So in your local chapter, you know, in San Diego or Los Angeles or New York, we have chapters where people can come together. So if any of you are a health professional of any walk in life, feel free to think about that. And then we do topics such as this. We'll talk about food intolerances and sort of walk through some of the details around that. So the other thing to think about, which a lot of people experience, is constipation. So some people experience diarrhea and constipation. We'll talk about diarrhea in a second. And sometimes it's related to irritable bowel syndrome, but sometimes people just have constipation that's not quote unquote IBS. And there's a lot of different reasons, but most important is that we think about, do we get enough fiber? And often vegetables can really provide the fiber and the phytonutrients and change the microflora in our gut lining so that our bacteria in the gut lining changes in a positive way, which all helps our bowel movements. And then fluid intake. A lot of us don't drink enough fluids. And so even if we do everything right, we're basically everything gets dried out because all the water that we were talking about earlier gets absorbed out of the gut, small intestine and large intestine. And then stuff can't move because there's not enough fluid. Exercise clearly is really helpful. I'm not a huge fan of laxatives. If people need them in the short term, they can use them. But often fiber through vegetables or psyllium can help. Chia seeds, there's a range of ways to get fiber. And if all the above isn't sufficient, then sometimes short-term use of laxatives can be helpful. What about some of the consequences? So, as many of you may have experienced yourselves, you know, you can get hemorrhoids. So if you spend too much time on the toilet, which unfortunately more and more people do because they love to be with their phones, which is a whole nother conversation. Obviously, we shouldn't be with our phones when we go to the bathroom or touching our phones. But people spend a while there, and then hemorrhoids are like a varicose vein. So think there are veins that are at the bottom in our rectum, at our anus, and they start to get dilated like a varicose vein does because of pressure. So spending a short amount of time on the bathroom and the toilet is best. You also can get diverticuli, which are these outpouchings that happen through the outpouchings of the actual intestines themselves, have these little outpouchings, and that can cause diverticulitis for some people. And colon cancer. Why? Because if things don't move through, if the transit time slows down, then meat in particular, red meat in particular, can lead us to having an increased risk of colon cancer. So, and obviously we have other symptoms as well. And so there's lots of different things to do about that. And I feel like the top half of the slide covers it for most people. If you flip the other side of the equation, and there's all sorts of different types of diarrhea, what's more relevant really is just the ones like, do I have an infection? Is this causing, is it from an acute infection? Did I get Giardia because I went camping and drank the water? Did I eat bad food and I got E. coli from, some piece of meat or salmonella from chicken or vegetables, that had E. coli on it, et cetera. Or is it really related to things like lactose intolerance, where you can get osmotic diarrhea, where you're actually pulling the fluid into the gut and it's being pulled in, and that's why you're getting this diarrhea as well. Now, the exudative types are more of the colitis types. So you can inflammatory bowel disease, IBD, and that's more serious. And there's different types. There's ulcerative colitis, there's Crohn's, and there's others as well. But those are the most common ones. And that can cause diarrhea, and that can often be more serious. There's a series of different books that talk about diet and how that can play a role. And when that's insufficient, there's other sort of supplements you can try, but often people end up having to escalate and use medications as well. There's a whole ranking of medications as well. Someone had asked that question, and that's really as much as we're going to cover about that tonight. So irritable bowel syndrome, many people have this. It's actually a large minority of Americans. We don't have a clear diagnosis. It tends to be the diagnosis of exclusion, so we sort of rule out everything else first. The treatments around it relate to a lot we've talked about already. So the microbiome. I often will ask people to go through an elimination diet. And for those of you that don't know what that means, it's really eliminating lots of different food groups that people can be intolerant of. So what would that? So gluten, dairy, corn, soy. There's a range of different things. We suggest removing alcohol, caffeine, artificial flavors, sugars, additional sugars. So, and basically it's a clean diet that you do for a week, ideally a month, and then you'll see if your gut changes. And often if it does, you'll start to then, what you do is reintroduce food groups back in, ideally 1 week at a time, and notice how your gut changes. And obviously, ideally you're keeping a journal. And then you'll realize, oh, this IBS is actually most related to this food that I've been eating the whole time, and I've been attributing it to IBS. Fiber is another important piece, exercise, and then the mind that we talked about in the beginning really plays in a huge role. There's a couple different pieces. I think this is good for all of us, regardless of our health issues. It's really relates to all of us for our health goals, which is how do we manage our mind? How do we learn to separate our true essence of who we are as a being from our mind that runs its stories all day long? And so there's some different techniques. There's something called CBT, which means cognitive behavioral therapy. Cognitive behavioral therapy is often done like in an 8-week or 12-week run. You'll do it once a week. You learn different skills each week. You practice it at home. It's quite effective for many different health issues. It's been looked at for insomnia, for anxiety, for depression. It's been looked at for IBS. And then MBSR is mindfulness-based stress reduction, which is really a mindfulness-oriented meditation practice. It was originally sort of coined or came out of University of Massachusetts, a guy named Jon Kabat-Zinn, who's quite a special being, who really took meditation and made it a bit more westernized, a little bit more compartmentalized, a little easier for us to relate to. And they run an 8-week course as well. You can do that online, you can do it in person, you can find it anywhere. Kaiser runs it.
And then there's something called mindfulness-based cognitive therapy. So MBCT, which combines those two, which is the best of both worlds. The intention is to really become more aware that when our mind's running and sort of what our mind is doing, what the narrative is in our head. And so that's the mindfulness, become aware when it's happening. And then the cognitive behavioral therapy part gives us the tools to redirect and sort of quiet and shut down that turning narrative. And then the mindfulness makes us realize, oh, we've gone back to our spinning mind again. So they really work well together. So some great things to try topically for irritable bowel syndrome, like peppermint oil. It's been looked at. Iberogast is a mixture of 5 different herbs that include peppermint oil. It comes out of Europe, and it's also quite effective. TID means 3 times daily. And both of these can be quite helpful. It helps both with sort of the spasms some people can get, so that cramping sensation that some people can have, and it really works to help calm that. Chromolin's also used. Acupuncture's been shown to be really helpful as well. And for diarrhea predominant oriented irritable bowel syndrome, you might want to evaluate for bile acid malabsorption, because 1/3 of those people actually have bile acid malabsorption, and that's what's causing the diarrhea, which should lead to more of a fat-oriented problem. And people can respond really well to something that grabs that bile acid and takes it away. So cholestyramine is an example of that. So probiotics also been shown to be quite helpful. There's a randomized study that's several of them, but this one in particular I'm showing here, that showed that people actually did much better. Their pain was better, their bloating was better, urgency, and their global scores were a lot better. And so that's, this one in particular is this particular strain. So it's called Bifidobacterium, bifidum, and then this particular subspecies, right, is MIMBB75. So it's not just, go randomly grab some probiotics off the shelf. This is very specific. And as we get better, I'll just sort of a footnote talking about probiotics for a moment, we're really in the rudimentary phase now of understanding how these different bacteria operate in our system and how they affect us. And as over the next 5 or 10 years, we're really going to start to be able to refine much more clearly, like we've done in this clinical trial here, what's the specific strain or the combination of strains that we want for this particular issue. So we've done it, for example, for urinary tract infections. For women that have recurrent urinary tract infections, there's specific strains that have been studied. Here's an example with irritable bowel syndrome as well. The other thing that's been looked at is rifaximin. And rifaximin has been looked at in many different studies. This one was in the New England Journal of Medicine. This showed some improvement. You have, it's not gigantic, but definitely, 40% versus 30% improvement, which is something. So I would do it as a sort of second line agent to think about. All right, heartburn. A lot of us get heartburn. For what I tell a lot of people is, if you don't know when you're stressed, often ask your spouse or partner or someone, or good friend. They'll tell you the truth. And the other part is check in with yourself. So whatever your vulnerable spot might be, for example, it used to be my back. So I used to have back issues. That was sort of my trigger. When my back was bothering me, I knew that I was not taking care of myself or feeling more stressed. For a lot of people, it's heartburn. So they get sort of this pit in their stomach that it doesn't always have reflux necessarily, which is a classic heartburn. Means reflux, it's coming up and you feel a burning sensation. But you can also have dyspepsia, which is just this discomfort that's in this region that's sort of just in the shoulder plexus, if you will. So what I often do is ask people to explore, like, well, when does it happen? Is it first thing in the morning, before you have food? Is it upon eating, when you just started eating food? Is it after you've eaten food? Is it only with certain foods? Is it when you eat too much? Is it when you eat too much too late in the evening and then go lie down? Another big piece relates to it is sleep. So what is our sleep hygiene? And poor sleep hygiene leads to more increased risk of heartburn for a whole a different range of reasons, including stress being one of them. What kind of supplements are helpful? So once you sort of figure out, well, I played with the timing, I'm trying to eat less at night. Ideally, you finish eating 2 hours before bed. If you do go to sleep and you're having heartburn, and some people, they'll tilt their bed up. So you don't actually prop yourself up with more pillows, because if you just prop yourself up with more pillows, you're at risk of then buckling at where the belt seam is, and then you get more reflux actually. So you actually want to take bricks or some sort of space occupiers and put them underneath the head of the bed. So the whole bed gets lifted up a little bit. And by raising that, then you've then shifted your whole body. So now gravity, you're taking advantage of gravity so that you get less reflux. So that's one piece of the conversation. Food choices. So clearly certain foods, chocolate as an example, smoking, for example, tobacco, will loosen and open the gastroesophageal sphincter, and that will lead to more reflux. Spicy food for a lot of people, fatty food for a lot of people, tomatoes. So for everyone, it's a little different, and everyone needs to sort of figure that out. There's a book in the group called, I believe it's Acid Watcher, which has done some great work looking at this. So supplements, there's a couple different approaches. Melatonin has been shown to be quite effective. It's good for sleep. And it also has been shown to affect the gastroesophageal junction, that GE junction, where that sphincter, that door that is between the stomach and the esophagus. And it will make it so it doesn't relax as much. So it helps with sleep and also helps with the reflux. So it's a great one to take, since people often get reflux at night. That's a great one to take. There's a range of Chinese herbal formulas that also have been shown to be helpful as well. There's something called D-limonene. D-limonene comes from a citrus, the peel of a citrus. And that it's usually taken every other day for about 20 days, 10 doses in total. Often needs to be repeated. That can often also help with dyspepsia or reflux. DGL is a licorice, where they remove the part of the licorice that causes increased blood pressure. So it's called DGL. And that also makes a coating as well that can be quite helpful. Marshmallow, plantain, DGL, these are all sort of coating around the stomach. Medications that many of you have heard of, the purple pill is one of them. Proton pump inhibitors, these PPIs, which we'll talk about in a moment. H2 blockers, Tums can work quite well as well. That sort of provides a nice coating as well. And so let's talk about H2 blockers and proton pump inhibitors, these PPI and H2 blockers. So there was this interesting study they did about 12 years ago now, almost more than 750,000 people. And what did they find? They found, so acid suppression associated with 50% increase in asthma incidence. So that's pretty interesting. So why is that? Well, it looks like there's probably a lot of silent silent reflux happening. So you're getting the gastric fluids that are coming, you're still having the reflux. And the question is, are you even having more? It's a little unclear, but it's not with the acid. And so that then comes up and actually comes down, a little bits of it come down into the airway, which causes increased risk of reactivity of that airway, causing increased risk of asthma. That's one theory. Another theory is it related to the medication itself? But there's no data to support that. It's just a theory. Other things that have been noticed with these drugs, as many of you may have heard of, is increased risk of hip fractures. We don't know why. Increased risk of aspiration pneumonias, particularly in people when they're in the hospital. Similar thinking about the asthma as well. Problems with kidney function. So these aren't benign drugs. Of course, they're widely disseminated, and so we're going to see these all the side effects much more easily because they're consumed by tens of millions of people. But it's worth noting, trying to figure out, is there a path to get off this? So what is it like to try and get off it? Well, let me give you some things to think about before that. So what happens when you have less acid in your stomach? So what do we use acid for? Why do we have acid in the stomach? So number one, it kills lots of things. So if bacteria comes down there or virus comes down there, it may help disarm that pathogen, number one. Number two, it needs an acidic environment to break down protein. So you can see here that protein gets broken into pepsinogen and then down into amino acids when your pH is nice and acidic. Ideally, it's around 2, typically in your stomach, 2 to 3. But when you take away the acidity of the stomach from these medications, like the proton pump inhibitor, then it doesn't do as good of a job breaking it down into amino acids. And so you have these partially digested proteins. And that can often, if they go across the border into the gut, from the gut into the bloodstream, you can get this immune response. And that's one of the concerns with these proton pump inhibitors, decreasing acid, which then leads to that protein not being properly broken down to small little units like they're used to, gets absorbed into the system, and the system turns around and goes, what the heck's this? And starts attacking it. So after 5 days of using proton pump inhibitors, you get this change in your pH, in your acidity in your stomach. So this study looked at this a bit to look at, well, what happens with your symptoms when you try and come off? And it turns out that when you start the therapy and then you see them plodding along there, if they keep taking the therapy, the medicine, they keep going along. And then when they stop, you can see an increase. The blue dotted line is an increase in their symptoms. And then after a while, it gets better again. So this was done in 48 healthy folks. They didn't have Helicobacter pylori. They were negative. And they were giving a medication called pantoprazole. So, and they were giving it for a month. And so you can see here, you know, really a big shift. And so the question is, why is this happening? And the thinking is that what happens is you take this medication, and so there's less acid, right? But what first happens is your body puts more receptors out there. They're trying to create more acid, and they're trying to get more of that happening because you're trying to quell the acid, so the body responds to it to compensate for it. So now you have more receptors out there trying to pump the acid in. Then when you stop the medication, what happens? They're still pumping acid in. All these receptors are helping push the acid in. And so now you have more acid being produced than you had previously because of this overcompensation. And then over time, it downregulates and comes back. So that's why people tend to get worse when they try and come off. So what can you do about it? Number one, start slowly if you're going to taper. And I recommend people typically go to 75% of their dose or 50% of their dose for a week. And then again, cut it in half by another 75 to 50% for the following week. I usually tell people to take 3-4 weeks to come off it. Of course, you know, the lifestyle things about foods, the things we talked about already that provide the nice coating. So the marshmallow I talked about, this licorice I talked about, the DGL, slippery elm, aloe vera. So sulforate's also a coating that you could use. The melatonin we talked about in Asparagus can be quite helpful, and that's been studied as well, taken 3 times a day for the month. And acupuncture as well. So I've had great success with people taking it slow and doing this package, and people do a lot better. I tend to have people continue on, ideally, the acupuncture, the lifestyle changes, so that we can get rid of this moving forward. Now, you have to keep in mind, of course, if this is persistent, you need to get it tested. Do you have H. pylori? Is that causing the problem? Do you need endoscopy? Do you need a camera to go down and look at the stomach to make sure you have an ulcer or some other cause or malignancy, which is rare but possible, that's causing your symptoms? All right. So leaky gut. I'm going to go through some of this since we have a fair amount of slides. I'm going to go through it relatively at a higher level, and we can always deal with questions on the backside. But the main thinking and theory that we should be thinking about is the fact that we have a really good gut lining, and you want that to be intact. And then when there's a breakdown, that gut lining is when you have problems. What are our modes of defense? We have a mucus barrier that we create. We have the bacteria that we talk about, the microbiome, and we have this local immune system that's really down in there, hunkered in, and works really well for us. When we test, there's some really cool tests. One of them is that you drink this stuff that has lactulose in it, which can give people, if you're constipated, it's a treatment for constipation. So you don't get too large of a dose, and it's supposed to just stay in your gut and go right out your poop. And then mannitol, and that one is supposed to get completely absorbed and come out your pee. So if some of the lactulose is found in your urine, that's a problem. And if some of the mannitol ends up in your stool, that's a problem. So that's how you can tell if you have either malabsorption or you have increased permeability. So if you had a lot of lactulose in your urine, there's permeability allowing that to happen. If you have if you have not very much of the mannitol in your urine, because it went out through the stool, that means things aren't being absorbed like they should. We call that malabsorption. So that's a great test. There's a couple other ones I'll show you as well, but that's a test that you can get. You just drink the fluid and then you take a urine sample and you hand the urine sample in. So this can happen from a range of different things. It can happen from alcohol use. It can happen for chronic NSAIDs, Motrin, ibuprofen, things like that. Infections can cause that as well. And so the main things to think about is sort of, and the second bullet really is, well, what affects what? So, if you take NSAIDs or ibuprofen, chemotherapy, stress, infection, that will break down the mucus barrier. The immune system can get all wacky if you're having food intolerances, again, from infection or stress. And then the microbiome can be thrown off, right? If you take antibiotics or you're not nutritionally sound, as well as infection and stress. So this is just a sort of a pictorial example of what we're talking about with a healthy intestine versus one where there's more permeability, where you can see on the bottom part, the bloodstream's at the very bottom, and you can see AB means antibody, and TTG-IgA is another sort of form of our immune system, which is the tissue transglutamase, immunoglobulin A. And so you have this substance that's able to make its way through into the bloodstream, and then your body has a systemic inflammatory response to it, which is the purple stuff all attacking this foreign entity. Whereas up top, it's being deflected, right? You see it's not crossing because everything's nice and tight, and certain immune functions out there, either it's our own bacteria or other aspects, are just stopping that from actually making its way through. Now, in addition to the drinking test I mentioned, the mannitol and the lactulose, there's also a blood test. And this blood test is another way people can do it. It's a little simpler because you just do a blood draw. And it looks for antibodies that you've developed to the small intestine lining itself. And so this is another option. This company is called Cyrex. I have no financial arrangement with any of these companies, but they do a good job looking at this, which they call array number 2, and I'll show you later on some other tests that they do that look at food groups, gluten in particular, or cross-reactive gluten food groups, or a broad range of food groups, to see if you're having food intolerances as well, or what they call antibody reactivity. So here's another sort of different picture of the brush border that I showed you before, and the bottom part, so you can sort of see here the tight junctions, and you can see the apical membrane. And the take-home message here is, wow, this thing regenerates every 3 to 5 days. So, and that's partly why, for example, with chemotherapy, people have a really hard time with nausea, diarrhea, vomiting, because the chemotherapy often attacks cells that are dividing rapidly, because the cells divide rapidly if it's an aggressive tumor. Same with our hair. And so with our gut, you'll see that people have this problem, and it relates to, because it's a rapidly regenerating cell. But the beautiful thing about it is if it gets damaged, it can just turn over and regenerate itself. So what are some of the treatments for leaky gut? There's a huge list here, but the main theories, the thinking is something called the 4 R's. Some of you may have known the cookbook that I wrote, I co-authored with Amanda Haas, who called the Anti-Inflammation Cookbook. And that cookbook, we talk about the first 50 pages, sort of was my part of it, really talking about the gut and gut health and what different food groups and why certain food groups can cause problems, and what we call the 4 R's. So removing the offending agent, replacing, repairing, and restoring and re-inoculating the microbiome. So we talked a lot about already removing stuff, right? So back to the elimination diet, medications that may be causing problems, things like that. Replacing, so sometimes we don't produce enough acid, like I mentioned earlier, and so you could use something called betaine hydrochloride, and particularly in the elderly, that may help produce more acid and create the right acidic environment you need to digest things better. Some people need digestive enzymes, pancreatic enzymes, for example, to help support digestion of fats and proteins. And then there's repairing the gut itself. So there's a range of different nutrients and herbs people use, like berberine being one of them. Glutamine is really helpful. Remember I talked about the repair of that brush border, that thin lining, and that one uses glutamine and just eats it up and uses it to actually heal the cells so they can repair. Same with NAC, which is also good for the liver, and zinc carnosine, which is really great for bowel injury, including stomach. If you have ulcers in the stomach or in the esophagus, zinc carnosine, not normal zinc, but zinc carnosine in particular, not zinc glycinate you might use or other zincs you might use for the common cold. This is different. Zinc carnosine has been shown to be quite helpful. And then fiber. And then reinoculating with the right bacteria, in your gut. So this is some other examples for food sensitivity. This is the array 3 of that company. There's a few different companies that do this work. But you can see here, so for most Western conventionally trained docs, they just order the standards. It's usually typically 3 different things they look for. It's an IgA, which is a sort of a side note. Then they look at TTG. They'll do 1. I think it's the TTG 3 or 6. I forget. You could see here that this is got 2, 3, and 6. Actually, this is an older slide, and the newer slide has even more versions. And then one other. And so basically what this has is a full array of the proteome that you might see in the gluten. So there's a whole bunch of different types of these proteomes that you'll find here that aren't being tested. So this is much more sensitive. And I can't tell you how many times this has been positive when the conventional, they'll come back, they'll say, well, I saw my regular doc and they ordered this one test and the TTG was negative and the endomesoidal antibody test was also negative, and then we run this test that's positive, and then they stop gluten and they feel better. There's more tests. This is another one. A lot of these food groups, if you have a problem with gluten, you may have a problem with these food groups, dairy, and the rest here that's listed. And then the microbiome. And the take home here is there's many influences on the microbiome, and so certain factors that favor things that are helpful. And again, you'll see this over and over again. So some of this stuff is just, you're born with it. It's our genes in the upper left-hand corner, right? Favorable genetics. Breastfeeding is really important actually to a healthy microbiome. And natural birth versus C-section, for example, high fiber diet and what exposure you have to microbes. So that's sort of, if you think that through about the factors that can affect, a healthier symbiosis, and then trying to reduce our inflammation and the integrity of our gut, and really helping these T helpers and T regulator cells are really our immune system, and getting those, and same with our neutrophils, so get those balanced. And that relates to stress. It relates to a lot of the lower pieces you can see down the bottom. So a big thing I want you to just keep in mind is we are mostly not human cells, okay? We are 90% bacterial cells, which is shocking. 100 trillion bacteria, 3 pounds of body weight. Apparently, most of our stool is bacteria or byproducts from bacteria metabolism. So what does that mean? We live in symbiosis with these other organisms that are on our skin, they're in our mouth, they're in our cell lining, they're in our gut. Some of them are pathogenic, most of them aren't. And we need the right ones in us and sort of colonized around us and within us to really live a vital, healthy life. And what's shocking is how lifestyle plays a huge role in that. So SIBO or SIBO, a lot of different sort of things to think about here, but the bottom line is a lot of times the colonic bacteria ends up in the small intestine. So the large intestine bacteria ends up in the small intestine. Colon is the large intestine. It can happen if you have problems with your your ability to have good peristalsis. And so, for example, with diabetics, this can happen to them, and so therefore their peristalsis can be problematic due to the nerve innervation of the gut, and that can cause a problem. Diverticuli, and some people get intermittent bowel obstruction. So symptoms are pretty generic. It's not something you'd be like, oh, you have SIBO immediately. Some people notice certain scent of their sort of burping. A lot of people have sort of these sort of more vague symptoms, and so it's something that clinicians really need to keep in mind. So the main thing that people do is the breath test, which is pretty simple, and it's not super accurate, but relatively accurate. And you can culture, but that's quite invasive. You actually have to go down there and scoop up some of the material and culture it. So typically people use a hydrogen breath test. And the treatment is relatively simple. It's an antibiotic, Rifaximin, which you saw before for IBS, or some people do levofloxacin and Flagyl as well, and probiotics. So those are both helpful. Now, I will note there are some studies, or a study or two, that showed that probiotics can cause SIBO. So if I recommend people sometimes experiment, come off their probiotics and see if they're feeling bloated or not right. They should come off their probiotics if they're taking them and notice if they feel a difference, and actually talk to your doctor about, hey, I've been taking probiotics and ever since then, something's a little different. It's worth noting and thinking about small intestinal bacterial overgrowth, because some of the bacteria the healthy bacteria that we're taking that you take, there's large intestine bacteria, and they belong, if your system's functioning right, it won't reside in the small intestine because the terrain isn't correct for it. So it just moves on to the large intestine. But if your terrain isn't in homeostasis, in proper symbiosis, then the large intestine bacteria will say, this looks good, and it'll set up shop in the wrong part of your intestinal tract. So what about gas? We can all relate to gas. I'm sure we've all had it at one point or another. Think about SIBO, that's one. So you have gas-producing bacteria in the small intestine, right? Instead of being in the colon, it's up in the small intestine making gas. You can get malabsorption of carbohydrates and sugars. So those are often sort of the main ones just to be thinking about. The other thing I will say, because I haven't mentioned it yet, I'll just mention there's a great use of bitter herbs, which for a lot of these different issues can be helpful at the symptom level. So if if you eat too much, so Thanksgiving, I always bring out our bitter herbs, non-alcoholic herbs. So you may, if you like a Manhattan or other drinks, you may know that, like, Angostura bitters and these other bitters. These bitters are really quite helpful for pain, cramping, and digestion. So eat too much, I would try bitters. I use a company called Urban Moonshine, and they make a great digestive bitters, and they can be quite helpful for gas pain, overeating. If you ate too much and you're getting reflux from it, you try it. It can be quite helpful. So in general, dietary habits, really a lot of this digestive stuff relates to our diet and sort of what we put inside of us. So my rule of thumb is if it's got more than 5 ingredients on it, probably not something you want to eat. If you go to the produce aisle, you notice there's no ingredient list. Like you're looking at broccoli or you're looking at a carrot, it doesn't have to say carrot because that's what it is. And then when you need to look at the ingredient list, if you can't understand the words, also typically problematic. Every serving of vegetable you have reduces your risk of badness by 6 to 8%. Badness basically across all health parameters. So all-cause mortality, as well as cancer, as well as heart disease, as well as respiratory infections, as well as autoimmune disease risk. I mean, this study that's looked at this, there's a few now that have looked at this, with every serving. So if you go from 1 serving a day to 2, that's great. Those that ate 7 or more servings a day were at 42% reduced risk of all-cause mortality. So with each serving, they showed a reduction or improvement, I should say, in health. Fiber, sufficient fluids, the probiotics we talked about, fish oil, I think can be quite helpful for many people. Ideally, get it through food, through fish, unless you're vegetarian or vegan, in which case you can get it as a supplement, fish oil supplement, or if you're opposed to that, then you could try it through algae. And then vitamin D, I'm not a huge fan with taking too much calcium, and the reason being that we've overprescribed calcium historically. And so if you do take it with calcium, typically you want to sort of strive for 1,200 milligrams in a day of calcium total from food as well as supplementation if you need it. We used to recommend, 800 milligrams total. That some people in the US now are recommending 1,200. That we used to recommend 1,500, but the UK has really changed their guidelines and I agree with that literature showing 800 is typically sufficient. And the reason and the concern is that people with higher amounts of calcium have been shown to have the increased risk of heart disease. Some people poo-poo those studies, but the calcium benefit on bone health is actually not as good as we used to think. And so I think people are better off at the 800 milligram target, which is what the National Health Service in the UK is now recommending. Great, so that covers where the grand tour. We're at the mark at 7:30. Those that need to leave, feel free to, but there are a few questions and I thought I would go ahead and ask some of those or address those. So let me go ahead and ask some of these here for a moment. Do you put any stock into testing like Viome where they tell you something, tell you someone what foods to favor or avoid? Yeah, so there's a lot of companies out there now that are, they do a couple things. So one, they'll say, this is the kind of bacteria that's in your gut. Then there's companies that are taking a step further and saying, this is the type of bacteria in your gut. And since we know that, then we, therefore, let me just adjust things a moment here. So since we know that this is in your gut, we think that these bacteria indicate that you're at increased risk for diabetes or that you don't digest these type of carbohydrates correctly. And that sort of thing is still speculative. There's a company out of Israel, there's a few companies, Viome's another one of them, that are really doing this work. I've seen mixed outcomes, so I think it's still early, but I think it's worth people, if people are interested experimenting with it. I don't put a whole bunch of weight into it yet. I think there's not enough literature out there to really support it. So some people are using coffee to become more regular, and people want to know, is there a way to get off of the coffee? So again, there's two parts of that conversation. So one is the lift we get from coffee. The part of the problem with the lift we get from coffee is sort of like taking a horse that's tired and then you're beating the horse. That's basically what we're doing to our own system. So obviously we want to sort of back engineer that, get better sleep, do more things that around meditation or yoga or things that calm our nervous system so we can have more energy through the day and identify other foods or indoor air quality, for example, that can affect our general health. So that's one part. The other part is simply it helps my bowels move. And again, if most people do pretty well if they slowly come off it and increase fluid intake, fiber intake, exercise. My grandmother swore by doing inversions in her yoga. She started yoga when she was 85 and did it for 21 years until she passed. And she would do morning inversions, and she swore by those inversions for her constipation. So I could pass that on as, it's not a randomized controlled trial, but she stopped doing them by order of her cardiologist, felt miserable, and went back to doing them again. There is pH testing. So people are asking about, how do you check your pH level? A gastroenterologist can do a pH check. It's invasive though. So they would go down there and sample the fluid to determine what your pH is in your gut. Where do you get DGL, marshmallow root extract, etc.? You can get these herbs in a range of different places. Pharmaca, where I used to be on the medical advisory board of, I no longer am, but I still am a big fan of them, and they're good. If they're particularly on the West Coast, you know, from California onward. So that's one option. And then other good sort of companies, you know, that are out there. What I tell people to do is look for ideally a third-party verification on the product, so that it's been independently verified on their quality. That's the best company to use, and a lot of those companies, such as Integrative Therapeutics, Jarrow, Thorne, Metagenics. We use a lot of Zymogen, which is a health professional line. There's a range out there. So diverticulosis, those that have diverticulosis. So we used to tell people to avoid nuts and seeds. We no longer tell people to do that. There's a question asked about that. What nuts should we avoid? You can eat your nuts and you can eat your seeds. Those guidelines that was anecdotal, never done on any formal research. Once they did some of the research, they found that actually that was no longer true. And they couldn't find anything to support that. Let me just see if I have anything else that I want to cover. I think that covers it. Anyone else have any other questions you want to pose before we close up? We're at 7:35, so I'd like to end on reasonable time. So thank you for your time. It's been a pleasure. We do this once a month. Feel free to come back. We'll send out another email to everyone who's interested. Please feel free to go to my YouTube site. We'll post this up there. If you want to share it with others, feel free to. And it's Dr. Brad Jacobs. So thanks for coming, and look forward to seeing you again. Bye-bye.